because when
Right.
you watch the whole video, you can hear the administrator saying to the guy who was holding the phone, saying, "What's happening? What's happening?" You know?
But I feel like, why aren't they coming down? Why are they just on the phone?
It's kind of too bad
You hear
nobody
your nurse
did.
Screaming, I'm pretty sure as like
Yeah.
even a nurse. Management, I would want to be there. Like, what's going on with my nurse?
Yeah. And you know, think about it. Okay, go ahead.
I mean, there has to be a supervisor somewhere.
Yeah.
Right, exactly.
I think she
Or
was
another
one of
coworker,
the,
right?
like she was one of the managers.
Where's your coworkers? Yeah.
Where's your charge
What are they gonna
nurse?
do?
Right.
Like the police, I guess. Like,
So
Because
that's
they all
why
get
there's
arrested.
probably more to the story than is apparent.
Yeah.
Yeah, definitely. But
I
I'm
think she
thinking,
was one of the managers or something at the facility because when you watch the whole video,
yeah, I thought she was the charge nurse or something.
Yeah.
LPR.
there it was her and the guy.
Yeah, you know what, I think you're
They're,
right.
like, two of the main people.
Well, that's-
yeah.
but then you think too, how can they have the right to take a charge nurse off duty like that too? You know what I'm saying? Wow.
Well, it just seems like a lot of excessive force. Just
Yeah,
she
that was-
grabbed her.
that
She wasn't
was-
fighting
Right,
anyone.
right.
She just wasn't throwing blood.
And,
And
then when they were like
yeah.
outside, the guy that their coworker, he stopped and he was like, "Why are you doing that?" and stuff like that.
Well,
So he
it sounds like
did.
the guy was trying to
Yeah, he did like try to intervene and like,
That's just a lot of force used.
Yeah, yeah.
But they're like, oh, if you're detaining somebody, if they're fighting
That's
you,
what police
technically,
do.
yeah, I was gonna say if
They're
you're
not
fighting
trained
an arrest.
to have a gentle technique.
I was gonna say if you're fighting their arrest,
They
they kind
like
of go full
lunged
force.
at her and she was just standing there.
Right,
It
right,
could have been like you're under arrest, and then who knows what she would have done. But
right, right. Right, if she struck out at him, but it's not apparent, you know, that happened.
Right.
So, you know,
did they ever get it? Because if I was another nurse and they just did that to her, I would be like, I'm not trying it either. You can take it too, but
you know, yeah, that's a good point.
Or they
Right,
could do it.
that's a
They
good
didn't want to
point.
get arrested.
Yeah, I bet they didn't get the blood. I don't think they did, actually. I thought too that police officer was having some like personal issues going on too, and maybe that's why he overreacted the way he did. I'm pretty sure I read somewhere that he was.
he eventually
Yeah.
got let go by from that force or whatever.
Yeah.
That
So-
apology was really pathetic too.
But I should have a whole
He
background
found
of it. I can't really.
I know.
People
So-
don't edit videos.
Yeah,
Yes.
they got a lot of that.
And there's always more to the story, like Kelly just said. There's
Yeah.
very good point for all of nursing and all of mental health nursing for sure. There's always more to the story that we don't know. And so we always have to take that into account. It's so easy to make a snap judgment, but there's always more to the story. But it's good to just get some conversation going and thinking about this, because this is a serious issue for nurses, having violence. And it would seem like we need some movement towards better laws that are protecting us from being abused. It is not, I think years ago, literally when I started in 1981, it was just like part of the job. You got beat up at work, somebody choked you. Oh well, it's just part of the job. It really shouldn't be. We just shouldn't accept it and sit back and say, yep, it's part of the job. And even aggression by, police officers, that would be a unique situation perhaps to the emergency room. But there are times when we might be victims to aggression by physicians. And it might not be physical, but it might be verbal. It might be demeaning. It might be, right? What were you just saying?
I was going to say demeaning.
Cindy?
I've heard a lot of physicians talk down to the nurses.
Yeah.
So
So,
it's funny, you're here for 5 minutes, the nurse has been here for like 12 hours, but okay.
right. So there's,
Sometimes
that's
patients to
definitely,
nurses, you mean, like when they try to do something, they're like, well, what's that physician say? It's like, well, okay, I recommended it to him.
Mhm.
I feel like that's demeaning, just not even physical abuse,
Yeah.
but
Yep.
verbal abuse.
Yep.
Like you wouldn't go into a bank and speak to someone that way.
Right.
But yet,
also
Right.
people will.
Well, that's true. Or even McDonald's. Again, my son would tell me the funniest stories of working at McDonald's and how angry people would get, and they'd order something that wasn't even on the menu, and they'd get all upset because you weren't giving it to them, just
people with their expired
funny.
coupons.
yeah.
Well,
Yeah.
Someone came in with a dead plant. I used to work at a grocery store, and they came in with a dead plant.
Uh-huh.
I've never watered it, and I was not going to give them a refund.
Uh-huh.
The manager made me look stupid because came down, gave them a refund, and then another person walked by
Oh
who had
dear.
heard the whole ordeal.
Uh-huh.
They were yelling at me that this plant was faulty.
Oh.
And daughter. And they walked away, because I couldn't say that to them.
Oh, right. Oh,
The
that's
person was
funny.
So mad. I was like, whatever. And we had someone burn cookie dough, and we gave them new cookie dough.
Uh-huh.
I don't know if you know the retail.
Wow.
The motto is customers always right.
Yeah.
Being in
Right.
management.
Right.
Honestly, just to avoid a whole argument or deal, I just gave it. It's not worth 15, 20, 50 bucks to me.
Uh-huh. Yeah. Yeah.
You know what? It's a big margin of corporations.
And that
They
could,
give about word by word. They're like, oh, they're so crappy at customer service. I don't want to lose 10 customers over 15.
and that can actually help the situation too, because then you're not getting into that confrontation. They're going there, they're angry, they want their plant, they want their refund, whatever, they want a new plant, they want whatever, and then if you're arguing with them, that's just maybe going to escalate things. So we do
You can't
have
really
to,
do that in nursing though. Like, if they don't want to ambulate, it kind of sucks to you because
Ah.
you get up.
oh, okay, so sometimes there are things that we have to force people to do that they don't want to do. Can you really force them?
Well,
I mean,
highly suggest.
highly suggest. Okay, we can't really force somebody to do it, but you can certainly tell them the doctor has ordered this, you need to get up, this will help you to recover, whatever. We certainly can strongly suggest and do some teaching as to why. If people understand why you're making them do something, sometimes they might be a little bit more accepting of it. You know, maybe I'm being hopeful.
Just bargain. If we go for this walk, then I'll leave you alone. We'll get in bed. Not even the chair. I'll get you in bed.
Okay, so
Lay down.
yeah, okay, so sometimes offer them an incentive. Okay, so anyways, comorbidities that go along with violent aggressive behavior, certainly PTSD. Sometimes patients with PTSD will just lash out, even if you just try to wake them up. You know, they're just that sensitive to excess stimuli. Substance abuse disorder. So the person that comes into the emergency room and they're intoxicated or they're under the influence of drugs, they are much more likely to behave in a bad way. So we hear stories all the time in report about people's behavior in the emergency room, that they were combative, they were aggressive, they were striking out at staff, and then they're on the unit, they're just fine because they're no longer intoxicated. So we also have depression, anxiety, psychosis, personality disorders. Any of those types of illnesses are real comorbidities. So application of the nursing process. So obviously do a general assessment, try to figure out what's going on. Trauma-informed care really means that we need to take into consideration the person's history. They may have a personal history of being abused. They may have all those issues that they maybe haven't dealt with. And so therefore, we are going to tailor our approach to take that into consideration. And we're not going to perhaps maybe set limits extremely firmly. We're going to try to figure out what is going on with that person and really take that past abuse into consideration. And self-assessment, we always have to look at ourselves and how do we respond to violence? How do we respond when somebody chokes us, even if they're not very strong? You know, how do we feel? How do we respond when those types of things happen? How do we feel in general about anger and aggression in nursing, and that we're going to be targets of that? And we might be angry back at the person. We may feel that it's their own, it's their fault. They're choosing to be this way. And some people are, if they're not under the influence of drugs, alcohol, they're psychotic or they're demented, they're not necessarily at that point in time fully responsible for their behavior. So lots of things to kind of think about with that. Alrighty. Case study. Mr. Oswald's paranoia continues, and he becomes agitated and threatens to assault a staff person. He tells you, "You're the only one I think I can trust, but can I? Are you going to take their side?" So this is a case study about somebody who has some paranoid issues. And when people are paranoid, they actually are at higher risk for violence because they're going to get you before you get them. Okay? So even if they're fearful of other people, that fear might make them act out. Okay, so keep that concept in mind. So the best initial intervention, say if you don't calm down, seclusion will be needed. Address him with simple directions in a calming voice. Help him focus by rubbing his shoulders. Offer him a dose of antipsychotic medication. Okay, B. Definitely B. You might eventually offer him a dose of antipsychotic medication, but the first thing that you're going to do is to address him very simple and and calmly. We never say, it's actually an evidence-based practice now not to say calm down to somebody. So I hope you've heard that before. Have you heard that? Yeah, you don't say calm down. You don't ever tell a person to calm down, because what's going to happen? They're just going to get more mad, right? They're just going to get more angry. You tell somebody to calm down. They're going to be, what do you think? Yeah, calm down. Of course I can't calm down.
When somebody's like, calm down.
Right,
They just get
exactly.
agitated more.
Exactly. Right. It just makes you feel like they don't really understand how you feel. They don't get that you're not getting your needs met, that you're upset, you're frustrated, you're angry. They don't get it. So, and we never want to threaten anybody, because truly that is also against the law. We can't threaten somebody with seclusion. A new nurse asks a coworker which patients are more likely to become aggressive or angry, and what are some risk factors that might predict some violent behavior. Say what? Okay, so somebody who's paranoid. We just mentioned a couple of things. Under the influence of something. PTSD. Person doesn't feel valued, the person that's not getting their needs met. Think about, too, in a general part of the hospital, people are uncomfortable, they might be in pain, okay? They might be in a lot of pain. They may be nauseous, they just might be feeling really quite physically miserable. So that can also impact the way a person behaves. All right. So some diagnoses we can use: ineffective coping, stress, overload. So again, you're in a new environment, bells and whistles are going off, and you're uncomfortable, maybe you're cold, you're too hot, you're sleep deprived, you're in pain, all different types of things. So risk for self-directed violence, risk for other directed violence. We're always going to have outcomes related to those, and the implementation are the interventions that we're going to do. So of course, the therapeutic communication is extremely important. So to be able to acknowledge somebody's distress and say, I see that you're really uncomfortable right now, is better than saying, what do you need? I'm busy right now, or don't you realize I have 10 patients? We've just got to put aside all of those frustrated, nurse frustration things that we sometimes convey to patients. We have to consider staff safety, so we always want to keep ourselves safe. On a mental health unit, what are some things that we do to keep ourselves safe, staff in general?
Don't wear any, necklace.
Right.
Stethoscope.
Dangly earrings, because dangly earrings are a target. People look at those and it's like, especially if you think about demented patients too. So you don't wear dangly earrings in the nursing home, right? So some people do, yes, but they shouldn't be. And actually some people in 1K, some of the staff even wear.
Yeah, I saw that and I thought of that.
Right. Necklaces, dangly earrings, no. Not a good thing at all. Stethoscopes around your neck you don't wear, right? What else do we do to keep ourselves safe?
In, to get your meds or even wherever, just to go into your room and make sure, have a way out in case the patient comes at you.
Yes.
Always face patients, never get back to them.
Yep.
Don't put yourself in a corner.
Yep. Don't get yourself backed into a corner. So when you're in there giving meds, you don't want to go on the other side of the bed toward the window and then the patient is closer to the door. We never want the patient closer to the door. You always want to be closest to the door in case you do have to leave in a hurry. Okay? So if you are worried about somebody, you can take another staff member with you. Okay? If you're thinking, they look a little agitated, they're looking a little psychotic, they're doing all these, they're punching walls or whatever, don't go down there alone. go take somebody with you and make sure other people are aware of the situation, so that just that general communication is really helpful. Doctors don't always do a good job with that. So this doctor went into a seclusion room by himself. So unlocked the door, just went in by himself, didn't even tell the nurses he was going in. And he had one of those nice French knit ties. And so he came out and the tie was like down here. So because the patient must have yanked on his tie, so he got out of there in a hurry. And I don't think he ever went into a seclusion room by himself ever again. So just that whole aspect of communicating with each other. Pharmacological interventions, absolutely, we can offer somebody a PRN. But usually the very first thing you want to do, so priority is to do that communication and just find out what's going on. How can I help you? What's upsetting? I can see you're upset. Tell me about it. We want to encourage them to talk about what's going on. Because if we can verbally de-escalate them, then we may never get to that point of them actually acting out and being violent. And then they're going to see us as more on, on their side. So we're trying to help them. Okay. Mr. Oswald becomes increasingly agitated when you come back from break. You find out he wants to talk to you alone. Your response is, respect his privacy and see him alone. Don't speak to him in private. It's time for the team to confront him calmly as a group. Ask for him to be put in restraints first or take security staff with you. Go speak to him in a non-confrontational way, but ensure that there are other staff nearby for backup. D. Yep. All right. Yeah, because you definitely want to respect him, and you don't want to show up with a whole group of people. That would be very intimidating for him, but you do want to have some backup there. So the implementation, health teaching and health promotion, we try to encourage people to cope appropriately, to handle. Everybody has anger feelings, so we just want them to be able to manage those in a safe way. So use of seclusion and restraints. There are times when we do have to resort to using seclusion or restraints. So seclusion, they're in a locked room by themselves. Restraints, they're usually in 4-point leather restraints. So when do you think, at which point do you think we would have to make that decision? Okay, so when somebody becomes violent to a point where they can't be controlled, assuming that you did what first? Tried everything else, right? You tried absolutely everything else. So,
There's even a deodorant on the mental health unit to put them in restraints.
I'm sorry, what?
Do you need a physician's order to put them on restraints?
Yes, absolutely. I think you probably need a physician's order in any setting to put somebody in restraints.
If you can't get it or right away, then what happens?
You can put, if it's a safety concern and you are trying to protect yourself and everybody else and the patient, you can go ahead and put them in seclusion or restraints, and then you follow up with calling the physician after. You can't wait to get the order first, because then the situation, people could get hurt. The situation is going to get out of control. You don't want to do that.
Is it like X amount of time to get the order, and if you don't get the order, then you have to like release them?
Well, you know what? If you can document that that person is that violent, I don't think you'd have to release them. But usually, I think it's a good amount of time that they have, like at least an hour or so.
I thought we learned about it was like 2 hours that a nurse could decide to do it, and then
Yeah.
after that they needed an order.
They would get an order. They would probably get that order pretty quickly, and I don't know that, I think the physician has to come within 2 hours. So again, that gives them a good amount of leeway. But they have to try to get that, at least call them and get that verbal order. But the physician then has to come and assess that person too, just to make sure, we don't want to be putting people into restraints when it isn't really necessary. So, but we can't just wait to get that order first, because then the situation could be really difficult. But yeah, there's lots of legal ramifications. So yes,
If they're like put in restraints, are they on a 1-to-1 then, or are they left alone in their room?
they would be on a 1-to-1. Yeah, very good question. You would not want them by themselves. We used to have something called a full sheet restraint. That was actually pretty dangerous, because if we ever did leave the person by themselves, they could wiggle around and maybe even strangle themselves in this thing, because it literally was from their neck all the way down to their ankles. And even though it was all mesh, so it was it was kind of breathable, but there was like lamb's wool, like around the neck and around the wrist and around the ankles to kind of protect skin integrity a bit. But the thing around the neck, it was pretty tight. So if somebody kind of wiggled around, so you can't leave somebody by themselves in restraints or even if it's in 4-point leather restraints, there are people that wiggle out of those. So you wouldn't want to all of a sudden see them popping out in the hallway, that they've gotten out of restraints and, usually a nursing assistant would sit with them, and they would try to not use a float. They would try to use a staff member on the unit, because a float, that would not be a good situation to put a float in, right?
It was
So-
weird when I worked on a med surg unit. If we ever had floats and if we had a line 1/3, it was always a float test out with them.
Really?
Always a float, because they just thought it would be easier for them to do one patient then.
But a lot of
We always thought it was like that. That patient might have felt comfortable with the staff ethic consistency. Consistency versus this guy who comes and sits in the corner.
Yeah. It's really better to have staff that are familiar and comfortable with the unit. Absolutely. They know the policies and procedures better. They know how to call for help, and in case it's needed. We have to think about if somebody's in restraints for a long period of time, we also have to think about medical considerations. So they need food, they need fluids, we need to assess their skin integrity, right? All those kinds of things. Offer them bathroom breaks. That can be a little tough. So sometimes you might have to take them out of restraints. If you can't safely do that, you may have to give a man a urinal or give a woman a bedpan. But usually we would get security there and have the person escorted to the bathroom and then put them back in restraints. But usually by that point in time, they've had some medication and they're a little bit calmer. So, yep. All right. So we just kind of talked about that already. So indications then for sure would be something that is so out of control. They are an acute danger to themselves or others. We do have to document very clearly what led up to the incident, what measures, what interventions that we used as nurses, and then the documentation about why we ended up putting that person into restraints. If you don't have good documentation, it's not going to support your using this very restrictive measure. Usually at the end of a restraint episode 2, you try to do some debriefing with the staff. That's actually a very important thing. I don't know if they do this in emergency rooms too. To me, I think in an emergency situation, you might, maybe they have more access to people that help them with debriefing. But really, truly, a staff should sit down and think about what cues did we miss? Did we miss anything? Because violence rarely happens instantly. There's usually warning signs. You can see the person's pacing more, they're wringing their hands, their facial expression, their eye contact. Their stance, might look more aggressive. So we have to kind of make sure we're not missing some cues. And if we are, then maybe we can look back and learn from the situation. And also, it's a very uncomfortable feeling as a nurse to restrain another human being. To take all those privileges away from them, that now they're restrained or they're locked in a room by themselves. It's really very distressing. So to help nurses work through their feelings of that, it is a really good idea to do some type of a debriefing. Usually when people are released, we try to do one, if they're in restraints, one limb at a time. So if you release their right wrist and they start swinging it at you, you know that they're not ready to be out of restraints yet. If they do okay with that, they're appropriate, they're not striking out at anybody, they're not trying to undo the rest of their restraints, then you can tell that they're regaining self-control. So that would be the goal, would be that they are regaining self-control, and then you can eventually let them out. So you try one limb at a time and kind of see how they do. All right, so Mr. Oswald becomes violent. He's placed in restraints, and I think we kind of talked about what questions need to be asked in terms of debriefing. What could we have done? What did we do? Did it work? Didn't it work? Maybe Mr. Oswald needs a change in his care plan and some different interventions to help him. So we're caring for patients in general hospital settings, and sometimes they become violent and they have healthy coping skills under normal circumstances, but perhaps now they're overwhelmed. They're not happy with their diagnosis. They're very upset. They're, again, cold, tired, hungry, sleep deprived, in a lot of pain, and that sometimes just can tax people to their limits. There are patients that just have marginal coping skills to begin with. So we do have to think about those, those types of considerations. So when you've got somebody in med-surg, has anybody ever had anybody in a med-surg setting that has just been really difficult to deal with and maybe even bordering on becoming violent? Yeah? Okay. So what do you do? How do you handle somebody like that? Do you have any examples? Or?
I got my supervisor because
All right. Nothing wrong with that.
that was
Yeah.
a long time ago.
Okay. So you had somebody else who had more experience try to help you deal with it,
And then I
with the
guess other
situation.
people who are not violent but angry, ask them, oh well, what's wrong? And
Okay.
then normally I can find a solution and then
Okay.
calm them down.
Okay. Right. So finding out what's going on. We can't assume what's going on, I guess. We have to find out what's going on and then try to help them to get their needs met as much as possible. And if somebody really is extremely difficult, great idea to get your supervisor, get somebody else involved that can help you with that situation. When somebody has cognitive deficits, so they're either elderly or perhaps they're developmentally delayed, that can be a little bit more challenging. And sometimes those patients really need very specific care plans with what helps them, what calms them down. They're actually doing something similar to that for all patients now on 1K. When you read their charts, you're going to find that they ask patients questions at least a couple times during their hospitalization. What helps you when you're upset? So, yep, and then what helps and what makes it worse? So that and it's going to be different for every single person. So, part of CUSIN, patient-centered care, that's a great example of patient-centered care. So for some patients, people in uniform, I'm just thinking of what some of the triggers were that made it worse for them. Seeing people in uniform was one of them, and I thought, well, shoot, I hope they don't mean scrubs. I hope they mean like police uniforms. But that was one of them, and talking loudly would be another thing that maybe would upset people. Being touched, they didn't want to be touched when they were upset. And then things that calmed them might be spending time in their room, listening to music that's soothing, being talked to calmly, being offered a PRN. It's so individual, but that's a really effective way to try to work with everybody, whether they have cognitive deficits or not. So finally, Mr. Oswald's restrained. As his nurse, what's your first priority? Debrief the patient, ensure the patient's safety, administer a sedating medication, or obtain an order from the healthcare provider. So based on our conversation, hopefully you'll get this one. What would be the very first priority? I'm hearing B, C, D.
Between B and D.
B is the absolute number one priority. Ensure the safety first, and then you're going to get that order. Well, actually, C and D, you might almost want to do at the same time. Somebody can be calling to get the order while somebody else is maybe going to get that sedating medication. Debriefing the patient would be way later, and you do want to review the episode with the patient to get their perspective on it and to help them understand what happened, why they lost control, and maybe what they could do to prevent that from happening in the future. And then which behavior is a criterion for mechanical restraint? Screaming profanities, assaulting a staff person, refusing a medication dose, or throwing a pillow at another patient. Definitely B. Throwing a pillow, well, you're kind of worried because they're starting to maybe get a little bit more. You would definitely pay attention to that, but it is not something that